Welcome. This is the New England Journal of Medicine. I'm Dr. Michael Bierer. This week, July 18, 2024, we talk about tenecteplase for ischemic stroke within 4.5 to 24 hours after the stroke, risankizumab versus ustekinumab for Crohn's disease, nirmatrelvir ritonavir as COVID-19 postexposure prophylaxis, and efanesoctocog alfa in children with hemophilia A, a review article on the management of insomnia, a case report of a woman with postpartum fever, abdominal pain, and skin ulcers, and perspectives on the ethics of relational AI, on anticipating the next pandemic, and on a first patient. Tenecteplase for ischemic stroke at 4.5 to 24 hours without thrombectomy. By Yunyun Shang from the Beijing Tiantan Hospital, China, and co-authors. Tenecteplase is an effective thrombolytic agent for eligible patients with stroke who are treated within 4.5 hours after the onset of stroke. This study evaluated the effectiveness of tenecteplase beyond 4.5 hours. In this trial conducted in China, 516 patients with large vessel occlusion of the middle cerebral artery or internal carotid artery who had salvageable brain tissue as identified on perfusion imaging and who did not have access to endovascular thrombectomy were randomly assigned to receive tenecteplase or standard medical treatment within 4.5 to 24 hours after the time that the patient was last known to be well, including after stroke on awakening and unwitnessed stroke. The primary outcome was the absence of disability, which was defined as a score of 0 or 1 on the modified Rankin scale, in which scores range from 0 to 6, with higher scores indicating greater disability, at day 90. Less than 2% of the patients underwent rescue endovascular thrombectomy. Treatment with tenecteplase resulted in a higher percentage of patients with a modified Rankin scale score of 0 or 1 at 90 days than standard medical treatment, 33% versus 24.2%. Mortality at 90 days was 13.3% with tenecteplase and 13.1% with standard medical treatment. And the incidence of symptomatic intracranial hemorrhage within 36 hours after treatment was 3% and 0.8%, respectively. In this trial involving Chinese patients with ischemic stroke due to large vessel occlusion, treatment with tenecteplase administered within 4.5 to 24 hours after stroke onset resulted in less disability and similar survival as compared with standard medical treatment, and the incidence of symptomatic intracranial hemorrhage appeared to be higher. In an editorial, Vivian Lee from Ohio State University Wexner Medical Center, Columbus, writes that a stroke that is caused by large vessel occlusion is the most severe subtype of stroke and is associated with a dismal natural history. Approximately 75% of patients with occlusions of the first M1 segment of the middle cerebral artery have poor functional outcomes. The use of endovascular thrombectomy during the 24-hour window after stroke onset has a substantial benefit for patients with large vessel occlusion. The number of patients that would need to be treated for one patient to have functional independence at 90 days is only 2 or 3. The unfortunate reality is that thrombectomy is not available in many developing countries, and worldwide it is estimated that less than 3% of patients with large vessel occlusion undergo thrombectomy. In the United States, only 1/3 of the population has direct access to thrombectomy within 30 minutes from their present location. In the trial by Shang and co-authors, tenecteplase resulted in a higher percentage of patients with this better outcome than standard medical treatment, as well as a higher incidence of recanalization. Mortality was similar in the two treatment groups, but symptomatic intracranial hemorrhage was numerically higher in the tenecteplase group. These results need to be replicated in other populations, and for clinical implementation, hospitals would need perfusion imaging capability. The use of tenecteplase during an extended time window provides a new adjunctive treatment option in our armamentarium against the most devastating type of ischemic stroke, and this has far-reaching global clinical implications. Risankizumab versus ustekinumab for moderate to severe Crohn's disease. By Laurent Perrin-Biroulet from the Centre Hospitalier Régional Universitaire de Nancy, Vendœuvre-les-Nancy, France, and co-authors. Interleukin-23 is a heterodimeric pro-inflammatory cytokine comprising a P40 subunit shared with interleukin-12 and a unique P19 subunit that plays a key role in skin, joint, and gastrointestinal inflammation. Ustekinumab and risankizumab are humanized IgG1 monoclonal antibodies. Ustekinumab selectively binds P40, and risankizumab selectively binds P19. This head-to-head clinical trial assessed the efficacy and safety of risankizumab as compared with ustekinumab in patients with Crohn's disease. 520 patients with moderate to severe Crohn's disease who had had an inadequate response to anti-tumor necrosis factor, TNF, therapy, or unacceptable side effects with such therapy, were randomly assigned to receive risankizumab or ustekinumab at standard doses for 48 weeks. In the full intention-to-treat population for the efficacy analysis, 90.2% of patients who received risankizumab and 72.8% of patients who received ustekinumab completed all the assigned treatments. Both primary endpoints of clinical remission at week 24 and endoscopic remission at week 48 were met. Risankizumab was non-inferior to ustekinumab with respect to clinical remission at week 24, 58.6% versus 39.5%, and superior to ustekinumab with respect to endoscopic remission at week 48, 31.8% versus 16.2%. The incidence of adverse events appeared to be similar in the two groups. In this trial of patients with Crohn's disease in whom anti-TNF therapy had failed, risankizumab was more effective than ustekinumab in achieving clinical and endoscopic remission. In an editorial, Clara Abraham from Yale University, New Haven, Connecticut, writes that head-to-head clinical trials provide valuable information for clinical decision-making and are much needed in the study of inflammatory bowel disease, which traditionally has compared therapies with placebo. The current head-to-head clinical trial by Perrin-Biroulet and co-authors showed that risankizumab was non-inferior to ustekinumab with respect to clinical remission at week 24 and superior to ustekinumab with respect to endoscopic remission at week 48 in patients with moderate to severe Crohn's disease who had had unacceptable side effects with anti-TNF therapy or an inadequate response to such therapy. A limitation of the trial is that it was open-label, which may have introduced bias. However, the central endoscopy reviewer was unaware of the patient's group assignments. Although it is tempting to conclude that targeting interleukin-23 P19 is more effective than targeting interleukin-12 P40 in patients with Crohn's disease, context is important. Possible reasons for the greater efficacy of risankizumab over ustekinumab may include specific differences among drugs with respect to their penetration of intestinal tissues and localization within those tissues, their relative affinity and inhibitory efficacy for their targets, and their association with immune cells, regulation of immune cells through the Fc region, or both. Furthermore, preclinical studies showed that interleukin-12 and interleukin-23 can play different roles at different times, with interleukin-12 playing a more important role earlier in the course of disease and interleukin-23 playing a more important role later. Additional head-to-head trials of interleukin-23 P19 and interleukin-12 P40 that evaluate distinct patient subpopulations will be important. Oral nirmatrelvir ritonavir as post-exposure prophylaxis for COVID-19 by Jennifer Hammond from Global Product Development, Pfizer, Collegeville, Pennsylvania, and co-authors. To date, clinical trials of treatments for COVID-19 have not shown a significant benefit of post-exposure prophylaxis. This Phase 2-3 trial assessed the efficacy and safety of nirmatrelvir ritonavir in asymptomatic rapid antigen test negative adults who had been exposed to a household contact with COVID-19 within 96 hours before randomization. 2,736 participants were randomly assigned to receive nirmatrelvir ritonavir every 12 hours for 5 days or for 10 days, or matching placebo for 5 or 10 days. Symptomatic confirmed SARS-CoV-2 infection developed by day 14 in 2.6% of the participants in the 5-day nirmatrelvir ritonavir group, 2.4% of those in the 10-day nirmatrelvir ritonavir group, and 3.9% of those in the placebo group. In each nirmatrelvir ritonavir group, the percentage of participants in whom symptomatic confirmed SARS-CoV-2 infection developed did not differ significantly from that in the placebo group, with risk reductions relative to placebo of 29.8% in the 5-day nirmatrelvir ritonavir group and 35.5% in the 10-day nirmatrelvir ritonavir group. The incidence of adverse events was similar across the trial groups, with dysgeusia being the most frequent reported adverse event in 5.9% and 6.8% of the participants in the 5-day and 10-day nirmatrelvir ritonavir groups, respectively, and in 0.7% of those in the placebo group. In this placebo-controlled trial, post-exposure prophylaxis with nirmatrelvir ritonavir for 5 or 10 days did not significantly reduce the risk of symptomatic SARS-CoV-2 infection. Efanesoctocog alfa prophylaxis for children with severe hemophilia A by Lynn Malek from the Versiti Blood Research Institute, Milwaukee, Wisconsin, and co-authors. Once-weekly efanesoctocog alfa provides high-sustained factor VIII activity with superior bleeding prevention as compared with pre-study factor VIII prophylaxis in previously treated patients 12 years of age or older with severe hemophilia A. This study evaluated the outcomes of efanesoctocog alfa treatment in children younger than 12 years of age with severe hemophilia A. 74 male patients received prophylaxis with once-weekly efanesoctocog alfa for 52 weeks. No participants developed factor VIII inhibitors. Most adverse events were non-serious. Among the serious adverse events that were assessed by the investigator, none were deemed related to efanesoctocog alfa. With this protocol, the median and model-based mean annualized bleeding rates were 0 and 0.61 respectively. 64% of the patients had no treated bleeding episodes, 88% had no spontaneous bleeding episodes, and 82% had no episodes of bleeding into joints. 95% of the bleeding episodes resolved with one injection of efanesoctocog alfa. Mean factor VIII activity at steady state was more than 40 international units per deciliter for 3 days and more than 10 international units per deciliter for almost 7 days after dose administration. The geometric mean terminal half-life was 40 hours. In this study in children with severe hemophilia A, once-weekly treatment with efanesoctocog alfa provided high, sustained factor VIII activity and highly efficacious protection against bleeding episodes in children with severe hemophilia A. In a Science Behind the Study editorial, Pratima Chowdhury from the Royal Free Hospital, London, writes that for more than half a century, the predominant approach for the management of hemophilia was factor VIII replacement therapy. Over time, the treatment strategy evolved from treating bleeding episodes to prophylactic therapy aimed at preventing bleeding. By reducing the frequency and severity of bleeding events, prophylaxis preserves joint function, reduces the risk of long-term complications, enhances quality of life, and extends the patient lifespan. Prophylaxis with clotting factor concentrates requires regular intravenous administration of the factor VIII protein. In children, the factor VIII protein has a shorter half-life than in adults, and intravenous administration of coagulation factors is particularly challenging owing to difficult venous access in children. In this context, a notable outcome in the study by Malek and co-authors is the achievement of once-weekly prophylaxis in children with sustained factor VIII levels through the week, which augurs well for protection in the context of delayed or missed doses. In the study, efanesoctocog alfa, as compared with standard factor VIII, showed a half-life that was 4 times longer and an area under the curve, AUC, that was 6 times larger. The increased AUC was associated with a more gradual decline in factor VIII levels between infusions, extending the duration of time spent in the normal range and improving control of bleeding with a marked reduction in the annualized bleeding rate. Moreover, no factor VIII inhibitors, antibodies against factor VIII, developed. However, the study participants had pre-existing tolerance of factor VIII because only those with previous exposure to factor VIII and without inhibitors were eligible for enrollment. As such, immunogenicity needs to be assessed in other patients, especially those with no previous treatment with factor VIII. Management of Insomnia, a review article by Charles Morin from the Université Laval, Quebec, Canada, and Daniel Bicey from the University of Pittsburgh Medical Center. Insomnia disorder is characterized by dissatisfaction with sleep quality or duration associated with difficulty falling or staying asleep and substantial distress or daytime impairments. The disorder is a sleep disturbance that occurs 3 nights or more per week, persists for more than 3 months, and is not the result of inadequate opportunities for sleep. Insomnia is common, and it frequently occurs when other medical, psychiatric, and other sleep disorders are present. Persistent insomnia is associated with substantial distress, functional impairment, and adverse health outcomes, including increased risks of major depression, hypertension, and work disability. Current guidelines recommend cognitive behavioral therapy for insomnia, CBTI, as a first-line treatment for persistent insomnia. CBTI includes practical strategies for modifying sleep habits, regulating sleep-wake schedules, reducing arousal from sleep, and reframing unhelpful beliefs about sleep and insomnia. Medications with an indication for insomnia, such as benzodiazepine receptor agonists, dual orexin receptor antagonists, and doxepin, that are approved by the Food and Drug Administration, are recommended as alternative or adjunctive treatments. There is inadequate evidence to support over-the-counter medications, antipsychotics, or alternative agents for insomnia. Recommended therapies for insomnia that include CBTI alone or with medication produce clinically meaningful reductions in insomnia symptoms, sleep onset latency, and time awake after sleep onset. These therapies can promote rapid and sustained alleviation of insomnia symptoms over time. A 30-year-old woman with postpartum fever, abdominal pain, and skin ulcers. A case record of the Massachusetts General Hospital by Joseph Marola and co-authors. A 30-year-old woman was admitted 6 days after the birth of her first child because of fever and abdominal pain. 6 days earlier, the patient had gone into labor at 35 weeks, 3 days gestation, and was brought to the emergency department. 8 hours later, the patient vaginally delivered a male infant and an intact placenta. On the second postpartum day, the patient was discharged home. During the subsequent 4 days, the patient pumped breast milk and visited her baby in the special care nursery daily while he was being treated for prematurity and feeding difficulties. During that time, the mother had mild diffuse abdominal and pelvic cramping and vaginal bleeding with occasional clots. On the day of the current admission, the mother had fever and chills. On examination, tender erythematous pustules that drained yellow purulent fluid were present in the inguinal area on the right side. The white cell count was 22,940 per microliter. Treatment with broad-spectrum antimicrobial therapy was initiated and she was admitted to the hospital. But the fever, abdominal pain, and leukocytosis did not abate. MR angiography of the pelvis showed ascites. 20 milliliters of purulent fluid was drained from a left parametrial fluid collection. Cultures showed no growth. New edematous, violaceous, friable plaques developed on the left upper arm, which subsequently ulcerated. As this patient's hospital course progressed, signs of systemic disease emerged: ascites, anasarca, hepatosplenomegaly, laboratory evidence of early disseminated intravascular coagulation, and possible right heart failure with associated pulmonary hypertension. The patient's fever, leukocytosis, elevated levels of inflammatory markers, pregnancy-associated disease, and possible pulmonary features were consistent with Sweet syndrome, an acute febrile neutrophilic dermatosis with pathergy that can be associated with pregnancy. The Ethics of Relational AI: Expanding and Implementing the Belmont Principles, a perspective by Ida Sim and Christine Cassell from the University of California, San Francisco. November 2022 marked an inflection point in the public's experience with artificial intelligence when ChatGPT, a large language model, LLM, chatted with millions of people in everyday English. LLMs belong to a new class of AI called generative AI, Gen AI, and generate natural language, the medium in which humans communicate with each other. Gen AI thus constitutes relational AI, which is qualitatively different from predictive AI. Gen AI's relational nature raises additional ethical questions beyond the already daunting ethics surrounding predictive AI. The 1979 Belmont Report established basic ethical principles for research involving humans: beneficence, respect for persons, and justice. These principles are also often applied to clinical care. Traditionally, physicians have held fiduciary responsibility for upholding these principles in the best interests of patients. The ethical calculus changes, however, when AI-generated text, speech, images, and video are interposed between clinicians and patients. In these situations, clinicians themselves are subject to AI and therefore also deserve beneficence, respect, and justice. Therefore, within the framework of the core Belmont principles, further explication of beneficence, respect for persons, and justice is needed, as is expansion of scope to include clinicians and the broader society. These authors call for the creation of a national network of proactive health AI ethics centers that would develop foundational methods, create and maintain living guidelines, coordinate the development, testing, and evaluation of implementation strategies far beyond institutional review boards, monitor ethics implementation as it evolves, and identify and share best practices. Anticipating the Next Pandemic, a perspective by H. Cody Meissner from the Department of Health and Human Services, Washington, D.C. Reflecting on a pandemic that killed nearly twice as many people in the United States as the 1918 influenza pandemic, which had been the worst infectious disease outbreak in the country's recorded history before COVID-19, offers several lessons for pandemic preparedness and response. First, The COVID-19 pandemic led to extraordinary advances in vaccinology, resulting in the availability of safe and effective vaccines and demonstrating the ability of the medical community to rapidly address a major challenge in the face of an urgent public health need. Paradoxically, a second lesson is about the fragile state of the national and global vaccine enterprise, including issues associated with vaccine distribution and acceptance. A third lesson is that partnerships involving private, government, and academic resources were critical for facilitating the rapid development of the first generation of COVID-19 vaccines. Building on these lessons in the current inter-pandemic period, the Biomedical Advanced Research and Development Authority, BARDA, is seeking to support the development of a new generation of improved vaccines. Project NEJM is a $5 billion initiative sponsored by the Department of Health and Human Services aimed at developing next-generation medical countermeasures against COVID-19. This initiative will support double-blind, active comparator controlled Phase 2b trials assessing the safety, efficacy, and immunogenicity of experimental vaccines relative to approved vaccines in ethnically and racially diverse populations. These authors anticipate that the vaccine platforms could be adapted to vaccines for other infectious diseases, thereby enabling a rapid response to future health security threats. My First Patient. A perspective by Martin Ellis from Meir Medical Center, Kfar Saba, Israel. It was a small nodule. He had noticed it on the lateral aspect of his left wrist, just where his watch strap lay. No pain nor discoloration. 1 centimeter in diameter, subcutaneous, firm and mobile. Being a 20-year-old medical student in his clinical years, he knew exactly what the diagnosis was. Occasionally, the links of his metal watch strap would pull at the hairs on his wrist, so this bump was no more than a granuloma secondary to watch strap-induced trauma. No treatment necessary. Case closed. Not so, said his mother when she came to visit from out of town. He dutifully went off to see his family doctor, who promptly referred him to a general surgeon. A date was set for excision. The procedure was uncomplicated, and the pathology report read, nodular fasciitis, clear margins. No treatment necessary. Case closed. Not so. 6 months later, the patient noticed that the lump had recurred in the linear 3-centimeter surgical scar on his forearm. He was now in his 5th year of medical school and had completed a surgical rotation. So he took himself directly off to his surgeon. A date for excision, a simple procedure. The pathology report was forthcoming. Nodular fasciitis, clear margins. No treatment necessary. Case closed. Not so. 6 months later, the patient was now in his final year of studies. The lump returned. A more thorough history, a careful local and general physical examination, some tut-tutting. Nodular fasciitis shouldn't recur, you know. A date for excision, a simple procedure. No pathology report. Some weeks later, a call from his surgeon. I think you should come in so that we can discuss the path report. A fairly straightforward consultation. The histology that had been extensively reviewed unequivocally revealed dermatofibrosarcoma protuberans. Margins barely clear. This may have been the diagnosis all along. More treatment necessary. Case definitely not closed. A doctor who treats himself has a fool for a patient, goes the aphorism, and it is generally accurate. After many decades of reflection, however, Dr. Ellis is grateful that he was his own first patient. His illness experience has taught him lessons that he has attempted to internalize and call upon at the bedside. These lessons range from the avoidance of the flippancy and indifference that he encountered regarding his initial surgeries and at tumor boards, and extend to the cultivation of interest, care, and a desire simply to help, as displayed by his senior colleagues. In our Images in Clinical Medicine, a 26-year-old man presented with a 2-month history of a painless, reddish growth on his left eye. On physical examination, a sessile mass with vascular frons was noted on the surface of the inferior bulbar conjunctiva. A diagnosis of conjunctival papilloma was made. In another image, a 50-year-old man presented with a 3-day history of jaw pain, fever, and shortness of breath. CT showed severe dental disease with gas formation in the retropharyngeal space, chest wall, and mediastinum. A diagnosis of odontogenic infection resulting in necrotizing soft tissue infection, retropharyngeal space infection, and mediastinitis was made. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.